Yes, so, okay,
Right.
I'm gonna stick around for a few minutes in case, just, and then if I don't hear anything, I'm gonna tootle on to Ponca.
Okay.
Okay.
Gotcha. Good morning. Everybody made it through the exam. Can everybody hear me in Alva? Good? Woodward? You good? Ponca City? Can you hear me in Ponca City? Thumbs up if you can't. Okay. So how'd everybody feel about the exam? Good?
What?
About the test? Feel good about it? Everybody did?
Made me tachycardic.
Made you tachycardic? Well, we were just talking about, it's week 8, so we're halfway through the semester, and that's exciting. So today we're going to talk about the musculoskeletal system. Okay, so the objectives, I'll let you guys read that. All right, so we're going to talk about the skeletal system and talk about the different types of bones. You have your long bones, for example, your femur, and they're cylindric and they're the weight-bearing bones. So they're the big, strong ones. And then you have your short bones, which are like your bones in your fingers and toes, and they bear little weight. So the structures of the bones, you have the osteocell in the middle, and then you have the osteoblast, the builder of bone, and then the osteoclast, the destroyer of the bone. So the red marrow is very vascular and can bleed in excess if broken. So the red marrow, you know, we produce red blood cells. The yellow marrow is the fat components, and there's a risk for fat embolism if those bones are broken. And we'll talk more about that later on. So the essential minerals for the skeletal system are calcium, phosphorus, calcitonin, and vitamin D. So one of the things we want to really focus on that's going to come up a lot with questions is that you have to have vitamin D to absorb calcium. So that's why a lot of times you see those two things ordered together. So just get that in your head now because it'll come up more. So the function of the skeletal system, it keeps our body upright, supports the surrounding tissues, your muscles and your tendons, assists in movement through muscle attachment and joint formation. It protects your vital organs like your heart and your lungs. Manufactures red blood cells and red bone marrow. That's important. Provides storage for mineral salts such as calcium and phosphorus. And it continuously process and reabsorption and destruction of bones until you're about 35 years old, and then it starts to deteriorate. Let me see, I'm trying to use both my computers here. So you can see the joints in different parts of the body, here in the neck, through here, your hips, your toes, fingers. What is that? It's your elbow. So the joint space is where they come together. So you can kind of see in those pictures, the blue and the white, where they're connected. In the butt and in the skull, there's no movement. Those are synarthroidal. See up here, see how that connects there. You have the amphiarthroidal, and that's partial movement, like in your pelvis. And then you have the diathroidal or the synovial, and it allows free movement in your knees and your elbows. So you talk about a lot about the synovial joint. That's usually comes up quite a bit. Oh, I forget my screen over here is not touch screen. All right, so yeah. So the synovial joint, it's the most common type of joint in the body. So you can see that little bluish part that's in between the brown, like goes in through there. That's what they're talking about is a synovial joint. It's lined with synovium, which is a membrane that creates this fluid that allows for lubrication and shock absorption. So a lot of times when you hear people saying like, their nose, their knees, sorry, their knees is bone on bone. It's just referring to like they don't hardly have any cushion in there anymore. Let's see. An inflammation in the joints can cause painful conditions like arthritis, the big one, and bursitis. All right, so you have your smooth muscles that are non-striated, they're autonomic, controls organs and vessels. And then you have your cardio muscles, which are atomic, which means that they just, your body, you can't control those. They function without continuous control, like, or conscious control, like your heart. Your heart's made up of striated muscle. Skeletal muscle can be controlled by the central and peripheral nervous system. And they're the ones that contract and relax. Like if, when you move your body, your arms, your legs, that is your autonomic function or muscle, sorry. And then it shows a picture of tendons over here where the muscle attaches to the bone, and then ligaments connect bone to bone. Just kind of a little refresher. All right, so when we talk about aging and health promotion, it's a big deal. You see that a lot. There's a chart in your book that identifies different musculoskeletal changes and the effects on the elderly. So you can look at that. Okay. So on here, let's talk about, so decreased bone density increases the risk of falls. Exercise is real important to help with falls, to help with balance and muscle tone. The cartilage degeneration, where we talked about that bone on bone, arthritis, and we can provide comfort measures for that, usually like Tylenol, sometimes heat, sometimes ice. And you can have a decreased range of motion, and that affects people's ability to care for themselves. So like the elderly, you see them with arthritis, they have those aging symptoms or whatever, and that's when they start to lose the ability to take care of themselves. Let's see, atrophy, which is, the loss of muscle, and decreased strength. So with that, they encourage light weight bearing exercise. I've heard them even say like just cans like of vegetables or fruit. Those can be enough weight for the elderly to practice with weight bearing exercises. And then they have slowed movements. So be patient and allow them time to move. That's why we get a little cranky with old people, because they're slow, but we got to remember they have all these differences in their bodies changing. So health promotion, avoidance of risky lifestyle behaviors. So no, be careful with if you're elderly, probably jumping out of a plane or something. Take your vitamin D and calcium supplements. And we talked about that they go together. Talked about weight bearing activities. Walking is the best. And then fall prevention. Can you guys give me any examples of what they can do to prevent falls? Sorry.
Rugs.
Yeah, get rugs out of the way. I know a lot of people like pets. We all love our pets, but sometimes those can be at fall risk for people. Make sure the hallways are lit up, if you get up in the night or whatever and it's dark. See, what are some more we can think of? What about Alva? Can you think of any? Can you unmute yourselves?
Area rugs.
Yeah, and stairs, if that's stairs. Are there a couple other things you can think of? Maybe in the shower?
Like a non-slip mat if they don't have one, or, yeah.
Okay, yep, a shower chair, if there's a railing in the shower, those are all good. And then, of course, tobacco, smoking, and alcohol use can affect the musculoskeletal system. All right, so to assess for musculoskeletal, you're going to want to check their patient history. Have they had a history of any trauma. Maybe in the past, they've had like a broken femur. So they may have pain from, residual pain from that arthritis pain. It talks about pain management. What have they typically taken for their pain, or musculoskeletal pain? Take their history, do they already have a history of calcium deficiency, maybe? Also parathyroid disease, because that will impair the ability for the bones to absorb calcium. Occupations, hobbies, those could both be things that could be accident prone, and then allergies. You're going to want to ask about the family history. Osteoporosis is hereditary, and so is gout. Nutrition history. If they're lactose intolerant, they can't drink milk, or they can't have dairy. Lack of calcium or protein, and obesity, which causes stress on the joints. And then if they have any current health problems, ask about all the information, leading up to that problem. When did it start? How does it, affect your ability to move? What are your signs and symptoms? Do you have pain? If you have pain, what relieves that pain? And just ask them to generally describe probably what happened maybe that led up to their pain, they think. And then pain assessment, of course, is it acute versus chronic? So if someone's coming in with arthritis symptoms, that would be chronic pain. If they came in because they twisted their ankle playing basketball, that's an acute pain. And then what do they have any weakness? Myopathy, which is the depletion of the muscle tissue, or neuropathy, the nerve pain. Okay, so the physical assessment, you're going to check their posture. Are they able to stand up straight? A lot of times you'll see as people age, they start to lean forward. Those type of things, look for that. Their gait, or their balance, their ability to stay steady. So a good one with that, we found out with our med-surg clinicals is, when your patient gets up to walk, how are they doing? Are they steady? If you help them to the bathroom, are they strong? Are they weak? Do they lean to the side? All these type of things. And then kyphosis, lordosis, and scoliosis, which we'll touch more coming up. And then, of course, look for any swelling, deformities, or pain. Someone might have a foot drop, and that causes them to not walk, straight, or they, might have to wear an AFO for that. So those are all things to look for. So then the mobility and functional assessment, assess if they need assistive devices. Do they need a walker? Do they need a crane? Those type of things. And then the active range of motion and passive range of motion. For the neurovascular assessment, you're going to check your peripheral pulses, like we've been learning about, and you're going to compare the injured site to the non-injured site. So if someone has a big old swollen ankle, foot, you're going to check your pulses. And so in the injured foot, they may not be as prominent as they would in the non-injured foot. So you may have to use a Doppler if you can't feel the pulse. Your muscular system assessment, you're going to look for, of course, symmetry and strength. Do they have one shoulder that might hang a little bit more than the other, or they have one leg that appears significantly weaker? And then if they add resistance to movements, maybe if they're leaning on the muscle, the pain as they're walking, I guess, how people will hold their hip if it's hurting. And then, of course, the psychosocial, the disturbed body image, depression, and financial concerns. The financial concerns, why do you think that would be a concern? What do you think, Ponca City? Why do you think if someone didn't have the ability to move, that would be a financial concern?
If they're nervous about like not being able to pay their bills, they might not seek medical treatment in a timely fashion.
Okay. What do you think about their ability to work? Especially, manual labor. They can't work. That's very depressed, and that makes you very anxious. You can't pay your bills because you can't get to work, and because you can't do your job anymore because of the pain and your inability to function like you did when you were not having the pain. Oh, hold on, my computer timed out. Ah. Okay. Then we'll talk a little bit about lordosis, scoliosis, and kyphosis. So scoliosis is, hold on, I got my notes over here. It's when you see that curvature of the spine to the side, that middle one right there. And it can curve like a S or a C. A lot of times it's idiopathic. It happens, there's not really a reason it happened, it just happens, and it's usually in teens. When it's idiopathic like that, it's most common in teens. It can also be congenital, which is present at birth, and then neuromuscular, so from cerebral palsy or maybe from muscular dystrophy. And the symptoms, like I talked about earlier, the uneven shoulders. So if your spine's leaning, curving one way, your shoulders aren't going to be even. One's going to be lower than the other. They might have a rib hump, tilted waist, back pain, of course. The treatment, they'll try to use a brace, a back brace at first. If that's not, and that's in mild and moderate cases, but if it becomes a severe case or it gets worse, they will do surgery, and a spinal fusion is what they do for that. Then the kyphosis, where the upper part sticks out to the back and the inside curves in like a S. This is curvature of the thoracic spine. It has the rounded back or the hunchback, so you can see in that picture. And then it could be caused by poor posture. Scheuermann's disease which occurs in adolescence. And then osteoporosis or vertebral compression fractures in older adults. We'll talk about those fractures in a minute. And then lordosis of the lumbar spine, which is the sway back appearance. So you can kind of see. You can see that in pregnant women. Think about it. Their belly is pulling, obesity, weak abdominal or tight lower back muscles, spondylolisthesis, or spinal instability. To treat that, or the symptoms of that would be lower back pain, muscle tightness, and exaggerated arch in the lower back. For that, just correcting the posture can help with that. Physical therapy, weight management, and pain relief. So whenever we are doing our assessments, like we were doing this week, if you look at the patient from the side, think about like the kyphosis, you can see where the upper spine is like if you're looking at them from the side, you can see their spine, sticks out more like the humpback pose. And then the lordosis, if you look at that from the side, you can see the back comes in and the belly protrudes. And then of course on the scoliosis, typically that's easy. Well, it's not easy, but you can feel it when you palpate the spine, like it should just go straight up and down. And with that, it kind of might have a little bit of a curve, and some of them can be significant curve, the more severe cases. Okay, so, all right. So you guys covered all this in holistic, but we can kind of go over it because you need to learn the terms. Make sure you know the terms for the different movements. So you have your flexion extension, your abduction and adduction, the supine and pronation. So with the supine and pronation, supine, prone, think of that as you're just going to have to know that the body can be supine, it can be prone. So those type of things, you got to know those. Inversion and eversion, rotation, circumduction, and elevation and depression. So yeah, make sure you know those. All right, different labs that you would assess for bone function. Your calcium, phosphorus, alkaline, phosphatase, and muscle enzymes. Those would be, too far. Then for x-rays, you would ask if they did a CT scan, you would make sure that they weren't allergic to contrast or iodine or seafood. You would ask them, a good thing to ask them is simply if you ever had an MRI or a CT scan that's, have you had any issues with the dye? If they've never had one, then make sure you ask them about the allergies and the seafood allergy. And I gazed over x-rays, but x-ray is just your basic x-ray, MRI, and then bone scan. So they can do a bone scan. They can use that to like diagnose cancer in the bones. You can also detect arthritis, osteomyelitis, and compression fractures. They do put a little bit of isotope in there, and it goes in their IV, and it goes into the bone, so you can see all the bones. And that isotope is excreted in their stool and urine. I gotta get a drink. Okay. And so arthroscopy, before the procedure, it's typically an outpatient procedure. Light anesthesia, but they have to be NPO after midnight, just like any procedure. And they need to still have movement in the joint. They still need to be able to move that joint. The procedure, they insert a scope into the joint through small incisions. It's laparoscopic. How many incisions do they make, Tiffany? 2? Tiffany's a scrub tech. She's done it for a long time, and these are her favorite surgeries. They have instruments they use along with a camera to correct any abnormalities, and the joint is inspected with a camera. So they use a camera to look at it. After the procedure, you want to do a neurovascular assessment, check your pulses, check for warmth, check for cool skin, check for paleness, those type of things. And then, of course, just like anything, you want to watch for infection. They will need maybe physical therapy. Usually they can handle like outpatient therapy or like therapy through their doctor's office. They can kind of show them things to do. And then, of course, pain control. This is a picture of a scope in the shoulder. And it's used to diagnose pathological changes in the joints. In this image, like I said, it's the shoulder. All right. Question. The nurse is caring for 4 female clients. Which client does the nurse identify at highest risk for low bone density? What did you say? Yes, D. White women tend to have the least amount of bone density of any group, which makes them more likely to have osteoporosis and fractures. Question 2. The nurse has completed a health teaching about preventing musculoskeletal problems. Which client statement reflects understanding of the education? It is important to use a cane when I walk. I can drink a couple cans of soda daily. Walking 3 to 5 times per week is healthy. If it hurts to walk, I will ignore the pain. Yeah, walking 3 to 5 times per week is healthy. We don't want them to use a cane if they can walk, okay, because we don't want them to increase their risk of falling. But a cane is good if they're having issues, if they're weak. So a client is preparing to undergo arthroscopy for surgical repair. Which question will the nurse ask the client before anesthesia is given? Select all that apply. I'll let you answer this question, Alva.
All of the above.
Good job. Yep. You're gonna ask them when they last ate or drank because they need to be NPO for anesthesia. Ask them about their physical therapy consultation. You know, what are you gonna do after this? Do you have a plan? Is someone here to drive you home? Of course, you had anesthesia. Do you understand your post-care information? And then have you signed the informed consent, of course. All right. So that finishes up arthritis. Or no, assessment, sorry. Okay. So now we're going to arthro. Okay. Any questions about that? Everything we just covered? Nothing?
I have a question.
Okay.
Is it true that carbonated drinks make you, your bone density? Like you lose more bone density if you drink more carbonated drink?
I've never heard that, but I'm not gonna say it's not true, but I've never heard that. Okay, we did. But it doesn't mean it's out there, not out there. I just have heard it. All right, so this, we're gonna talk about different musculoskeletal conditions. The objectives here, we're gonna talk about osteoporosis and osteomyelitis and assessment findings. Teach patients how to decrease their risks. Talk about the different lab and diagnostic findings to diagnose those things, educating your patient about the common drugs used for osteoporosis and understanding treatment for osteomyelitis. So osteoporosis is a big one. So this is a chronic disease at a cellular level. The bone loss causes significantly decreased bone density and possible can lead to fracture. It's referred to as the silent disease because typically people don't know it until they break a bone or someone does a bone density exam. A lot of times when people are postmenopausal, a doctor will do a bone density exam to determine like their base level of osteoporosis, or if they even have it yet, so that as time progresses and they're getting less estrogen, because that can increase your risk, just a baseline to kind of make sure where you're at before, as you get older and time passes. The fragility fracture, a fracture that can be caused by low impact trauma, usually it's diagnostic. Osteomalacia is the bone loss related to lack of vitamin D. And then osteopenia, loss of bone mass. And then we talked about the decreased bone mineral density. Okay, so like we talked about, estrogen plays a key role in keeping bone strong and dense, especially in women. When estrogen levels drop, such as after menopause, bone reabsorption increases, meaning the body breaks down bone faster than it can rebuild it. So primarily more common in postmenopausal women because of the lack of estrogen we just talked about. Men in their 70s or 80s because they lack testosterone. A secondary reason someone may develop osteoporosis is from a medical condition. Talked briefly about the hyperparathyroidism because the parathyroid takes up calcium, which is coming from the bones. Long-term steroid use, prolonged decrease of mobility, and then spinal cord injury. Here's a little mnemonic, I guess, to remember your osteoporosis risk factors. Alcohol use, it's access. Alcohol use, corticosteroid use, calcium's low, estrogen's low, smoking, and sedentary lifestyles. So let's see, over here on the risk factors, it included genetics, nutrition, alcohol or tobacco use, gender, which is usually females, medications, and an ethnicity. So the medications would be like the steroid use. And then to promote healthy promotion would include safe sun exposure, exercise, supplements, and diet, and start doing those things young. I think it's kind of became more popular within the last, I don't know, maybe 10 years that they're really paying attention to your vitamin D. And basically everyone, it seems like their vitamin D level is low, but I'm sure as you age, it gets worse. But a lot of people have a low vitamin D level. Let's see. Okay, so this shows your spine as you age. So see this person starting out, they're 5'6", and then they start to hunch a little bit at 60 and they're 5'3". And then at their 70s, they start hunching even more and they're 5 feet. So when they say you do shrink as you get older, it's true. So it shows a normal spine of a 40-year-old with osteoporotic changes at ages at 60 and 70 years. And they can cause cause a loss as much as 6 inches in height, can result in the so-called Dowagger hump on the far right over here, and then in the upper thoracic vertebrae. So you see this a lot in women, but once in a while you'll see little old men too that are way hunched over. So when you assess a patient like this, you're going to look at their spine and back to see, look for that lordosis. Or wait, do I have the right one? Okay. Oh, the kyphosis, that's what I was. Joint and movement. The psychosocial would be quality of life and body image. They can't stand up as straight. They're not as tall as they used to be. Their lab assessment, you're going to check their calcium and vitamin D3 levels. On the diagnostic assessment, the DEXA scan is called sometimes, but this is what measures their bone density that they check when they become postmenopausal. And then x-rays, of course, of the spine, and then MRIs. So this shows some more about osteoporosis, where it's the dorsal kyphosis, where the back, get that hump back, and then the cervical lordosis, where the spine comes in as well. Usually this is caused by, what do you call it? Crush fractures, which we'll talk more about that when we get to the bone part. But at risk, you have slender females that are Caucasian. They drink alcohol, they smoke, and they use too many steroids, basically. And we talk about some interventions here. Make sure you're getting a good variety of foods. You want your proteins and your dairy and a variety of good green leafy vegetables, they always say, has vitamins in it for you. Combination of foods, so mix it up. Calcium and vitamin D, lifestyle changes, exercise, especially as the people get older, they really do need to do something, walking. A lot of elderly people like to go swimming, physical therapy, and stop alcohol and tobacco use. So when you have older people, or anybody really, I guess, that's having back pain, this is a way to relieve the pain of that lower back. See people use that position a lot in a semi-Fowler's position with pillows under the knees. All right, so different kinds of drugs. Of course, calcium and vitamin D3 replacement. It can be lifestyle and diet changes are the first choice, but then you can also supplement, obviously, with vitamin D. Let's see. Estrogen agonist and antagonist. They teach patients signs and symptoms of, with those medications, show symptoms of a vascular thrombotic embolism. But I want to get down to the bisphosphonates because that's what is a pretty common medication that's given. It slows bone loss by inhibiting osteoclast activity, the cells that break down bone, helps increase bone density. So there's a lot of nursing implications that go along with giving these type of medications. That the common ones, most common ones, are Fosamax and Actonal. But when you give these, the patient they need to be first thing in the morning, and they can drink a full glass of water, which is about 6 to 8 ounces, and taken on an empty stomach, 30 to 60 minutes before they eat any food. And then they need to be able to stay upright for at least 30 to 60 minutes because these are really erosive or irritating for the esophagus. So the goal is to get that moving out of their esophagus as quickly as you can down into the bloodstream. So do not lay down after you take it. Same thing, you don't eat, you don't lay down, drink a full glass of water. Make sure you continue with your calcium and vitamin intake, watch that. And then if you have any issues of like chest pain, difficulty swallowing or heartburn, immediately make sure you report those. And then of course the side effects could be GI upset, esophagitis, or esophageal ulceration. It can also cause muscle or joint pain. And then a rare side effect of these medications is osteonecrosis of the jaw. So a lot of times if people are taking these medications, they'll tell their dentist or whatever, and make sure you stress to your patients that if they're taking these medications, they need to tell their dentist that they're taking them. That's important. And a lot of times they'll give them antibiotics before a dental procedure if they're taking these medications. So there's a lot of things that go along with those biphosphonate medications. So if you see those, make sure you know all the ins and outs of it. Okay, 3 ways to fight osteoporosis. Get adequate amounts of calcium, get adequate amounts of vitamin D. How can you get vitamin D without taking a supplement? Being out in the sun, yes. And then exercise regularly. So if they're going on their walks and they're out in the sun, they're getting their vitamin D. Osteomyelitis. Osteomyelitis is an infection in bony tissue, and this is serious stuff if you get osteomyelitis. It can be caused by bacteria, viruses, parasites, or fungi in the bone, but most typically I've seen bacteria. There may be infection in the soft tissue as well. So infection in the bone, so you have the pathogen that enters the bone and it causes the inflammation. You have vascular leakage, exudate formation, there's a decreased blood flow, and then tissue necrosis begins, breaking down the tissue in the bone. An abscess can form, and it can also go to your system. It can be a systemic infection, which is bad news. So I want to talk a little bit about more about the osteomyelitis. It can be in your bone marrow and the surrounding tissue, and it's typically caused if it's by bacteria infection, it's staph infection, and it can enter the bone through the bloodstream. So infection in the blood, it can spread to other sites in the body through direct contamination. So if someone breaks a bone and it's yucky out there, you know, in the field or whatever, definite exposure to infection. Nearby infection spreads. So if they have infected tissues, like they have a diabetic ulcer on their foot, that's where you'll see a lot of it. The infection from the ulcer can cause inflammation, swelling, reduce blood flow, which can lead to bone necrosis, the death of the bone. And they can have a lot of pain with that over the affected bone, swelling, redness, warmth, fever, chills, malaise. So any of the common symptoms for infection, drainage from the wound, and they can have limited movement in the affected area. And the treatment is IV antibiotics long-term. So if you have a patient that needs long-term IV antibiotics, we're talking like 4 to 6 weeks, what kind of IV access would they need? Do you know Ponca City? If somebody's getting long-term IV antibiotics for osteoporosis or myelitis or any chronic infection, what would they need?
If they're getting long-term antibiotics,
Yes.
I don't think we know. I was gonna say.
Okay, that's okay. Do you know in Woodward? No? Alva? I thought you guys would have kept. And Enid, do you know? Yes.
Like a
PICC line. Yeah, you got it. A PICC line, yes, because it can stay in for longer amounts of time. It's easier to clean and keep it dressed, and because they're gonna be doing these in the home setting. Sometimes home health may be the people that come and administer it, and I've also known of home health teaching family members or whatever how to administer the antibiotic at home. But yeah, they have to adhere to the antibiotic treatment for that. Let's see, we talked about from the outside of the body, from the inside, from the bloodstream, and then contagious. We talked about those. Here's a little picture about osteomyelitis. Let's see. infection of inflammation, infection of the bone and the bone marrow. And this says adults, vertebrae and pelvis are usually affected. I honestly haven't seen that much, but it doesn't mean anything. And in children, the long bones are usually affected. It says 1 in 5 patients have septicemia, which is an infection in their blood. A big risk factor includes IV drugs and infected teeth. The IV drug use is a big one that you'll see osteomyelitis in. What do you think that could be from? Do you think they use a sterile needle every time? No. Symptoms, like we talked about, fever, bone pain, swelling, and redness. It's diagnosed typically with a X-ray, CT scan, or MRI. Treatment includes antibiotics and possibly bone surgery. They may go in and try to clean it out. Of course, complications can include a bone fracture and infection to the lining of the heart. So osteomyelitis can cause cardiomyelitis, which is another big important thing, but you'll probably learn more about that later. But back in ancient days, they used blowflies larvae as treatment. We don't do that, thankfully, anymore. And it may lead to amputation of the affected limb. So, sorry, it logged me out of my notes. All right, so things to watch for with osteomyelitis is obviously with bone pain. And you can see some redness or heat over the area of the infected bone, fever, elevated white count, positive blood cultures. As the disease progresses, you can see an elevated SED rate, MRI and x-rays. So I think a big thing when you're assessing for osteomyelitis is to be looking at other things that are contributing to it. Like we talked about the IV drug use, the diabetes, the poor peripheral vascular disease, things like that could have contributed to why they would get osteomyelitis. I think that would be important, a patient history to look at. And then there's acute and there's chronic osteomyelitis. So with acute, you'll see a fever usually above 101. There can be swelling around the affected area. There may be, you can see signs of like what you would consider cellulitis, redness, hyperpigmentation, and warmth in the affected area. It can be tender. And the bone pain is usually constant. It's localized to where the infection's at, and it's a pulsating pain. So if someone's hurting real bad, I don't know if you've ever heard, like, I can feel my heart beating in it, like it's pulsating because it hurts so much. And it worsens with movement. Now, chronic osteomyelitis is most commonly caused by foot ulcers or bone surgery. It can form in the sinus tract. It can cause localized pain, just like acute, and then drainage from the affected area because they have an abscess. Like if it's a diabetic ulcer, they usually have an abscess that caused it. So interventions, we talked about antibiotic therapy. It's usually 4 to 6 weeks, or it can be up to 3 months. We talked about the IV access. You're going to want a PICC line for this. Contact precautions, a lot of times you'll see MRSA with that. So they'll probably, what am I going to say? Culture for MRSA or for the bacteria to see what kind of bacteria they're growing. Of course, wound care will be a big thing, surgery, and then neurovascular assessment. Okay. Is it a good time to take a break? Let's see. Come to this computer. Okay, let's take like a 5-minute break before I start the next slide. Okay. So come back at 10:20-ish. All right.
Your side. And enough, Chelsea gets 40%, I get 60.
So where did, I know I had you guys at the hospital for clinicals, went to clinic. How was that? You didn't, no, you were with me. You went to a clinic. How was that?
It's okay.
It was okay.
Yeah, it was a long day.
Not as fun as the hospital with me.
No. It's very cool.
And so where did, no, I don't have you, Lindy. Stephanie, where did, or I don't have you either.
I was in med surg.
That's right.
Everybody else's patients were a little full moon.
Oh, yeah, there was a full
Mine
moon.
was cold, calm, black, she had pneumonia. She was kind of funny. She's like, I only smoke 3/4 of a pack when I go to the casino. Like, and I only drink when I go to the casino.
So she lives at the
She
casino.
said once a month, and I was like, oh. She
Funny.
was sweet though.
Where were you at, Lindy? Were you at Med Surg or?
I was at the clinic in Cherokee.
Oh, okay. Is that a Great Salt Plains clinic?
Yeah, it was pretty dead.
Yeah,
A lot of people came in for like flu shots though.
yeah. Yes. Tiffany, where were you? You were with transition and you didn't really, you saw a lot of IVs being started. Lots of IVs. Yeah, yeah. And Mary, where were you? What were you doing? What were you doing at Ponca? Med Surg? Do you have an interesting patient?
No, he was legit.
He was
He did
legit.
everything himself. All I had to do was just do my stuff. He did everything.
But.
Oh, he couldn't speak English.
Okay,
It
well,
was Arabic.
that's impressive. That'll be a good care plan.
Also, the tech lady, the translate lady, no one told me before I went in that I wasn't supposed to look at her on the screen. So here I am, I'm bobbing my head back and forth, and she like stopped me and was like, yeah, it's better if you just look at him so he feels more involved.
Stand back behind it.
I'm so
Yeah.
sorry.
Yeah, yeah. Well, I'm glad they used the translator iPad. I don't know what they call it, but for it, that's more professional.
My nurse sucked.
Oh,
My nurse made me very, very mad.
okay. Let's not talk about the nurse. Not right now. Well, you guys need to go with this on 4 North at St. Mary's. We got to remove an NG tube. We got to remove staples.
I know, I heard y'all like share the staple love.
We did.
I'm jealous.
Yeah, he had a lot of staples.
Oh, yeah.
I couldn't go.
I had a cool patient. I think y'all see it for an hour.
I tried to do another IV, but it didn't.
And I lost.
No luck with an
I
IV?
didn't work, Miss Margaret couldn't get it, and then the nurse, that was her nurse couldn't get it.
Well, you needed to call Tiffany's group. They're professional IV starters.
I need someone with nice plump thing, so I can get my COVID.
Now, that's one thing. They haven't got any chances to start an IV. Okay, everybody back? Well, let's get started. Okay. Arthritis, and we talked about arthroplasty already, didn't we? All right. So the objectives, we're going to talk about mobility in patients with arthritis, how to teach adults how to reduce their risk of osteoarthritis, teach patients and caregivers about the common medications to treat rheumatoid arthritis, and plan evidence-based nursing care to reduce pain and inflammation in patients with arthritis. Okay, so osteoarthritis, not to be confused with osteoporosis, is the most common type of arthritis. It's progressive in deterioration and loss of articular cartilage and bone in one or more joints. So you can kind of see on this picture as well, like we talked about before, you have the normal joint with the synovial in the middle, and then you can see the picture next to it where the bones get thicker and the cartilage, the synovial fluid in there, the joint starts to thin. It occurs more often in older adults, like I said, about less decreased synovial fluid and less body fluid. Yeah. So osteoarthritis, the etiology, and genetic risk. The primary osteoarthritis is aging, usually see it in elderly women, genetic factors, and then weight-bearing joints are most affected. So that would be your knees, typically your hips. Secondary osteoarthritis can be from injuring a joint, obesity, and repetitive stress on joints. So this is a picture of arthritic hands. So you can see the angular changes at the joints, and it's as a result of the loss of joint cartilage and instability, like we've talked about with the other bones. You can a lot of times see, I don't know if you guys have ever seen elderly people with bones like this. My grandma had hands like that. Ways to teach health promotion and to prevent the disease, maintain proper nutrition, avoid injuries, of course, take work breaks, stay active, and maintain a healthy weight. And sometimes, even though you're doing those things, you can develop osteoarthritis, but because of genetics or maybe medications, but still promoting these things can help maybe make it not quite so bad, not as many symptoms. So you're going to want to take a history whenever you talk to the patient about to look for cues of osteoarthritis. So joint pain may be a secondary diagnosis. How long have they had joint stiffness? You know, when and where has the joint swelling occurred? How much discomfort are you having from this joint pain? And have you had any loss of your mobility or ability to perform activities of daily living? So you want to, like what it talks about up here, the joint pain, it can be a secondary diagnosis. So when you're assessing that joint pain, look at these things and ask these questions to determine, could it be from osteoarthritis? Other things to look for would be your physical assessment. You'd look for persistent joint pain and stiffness, crepitus, which is that coarse grating sound caused by loosened bone and joint. It's kind of sometimes like when people bend their knees, you might hear that. Joint effusions and inflammation, and then of course the psychosocial, the lifestyle changes and the pain and how it disrupts their daily living. For assessment, other things to look for on the lab work, it's usually diagnosed on their history and physical, like if they're coming into the hospital, but you can look at their elevated SED rate or C-reactive protein. They may be elevated when synovitis occurs, which would be inflammation in that joint. Imaging assessment, you're going to look at x-rays for structural joint changes. A lot of times you'll see osteoarthritis. I think they put osteopenia. So I'm trying to think how they worded on the x-ray. I can't think of it right now, but it's easy to diagnose on just a regular x-ray. And then the MRI can determine vertebral involvement, because you can also see that in the spine with the vertebrae. Cause a lot of back pain. Let's see. So the priority for patients with osteoarthritis, they can have that persistent pain, which can cause swelling and cartilage deterioration. And then they have that potential for decreased mobility due to pain and muscle atrophy. So if they're not moving around because it hurts too much, they're not using their muscles and they can atrophy. Pain is a big thing. You want to address that. So for planning, you would want to talk about the managing their persistent pain level. You know, you want to identify with those people what their acceptable pain level is, because one person may say their pain's a 7 and another may say it's a 4, but then you ask the patient, you know, is that an acceptable level for you? And the patient will say, oh yeah, I can handle a 7, it's fine. But then the 4 may be like, oh no, it's the worst, it's terrible. So I always want you to think about following up with the patient and asking them, is that an acceptable pain level for you? Because I don't want us to automatically think they always need pain medicine or offer it to them. Because if there's other things you can do, like maybe a heating pack or something like that, repositioning can help with the pain. Look at those things as well, but kind of talk to them about what's acceptable to them. For chronic persistent pain, it can be a challenge for the patient and the provider to find things because typically it's anti-inflammatories, and a lot of those can have so many side effects and whatnot. It can be kind of challenging to find a treatment. And then multimodal approach to managing pain, what we talked about, the heat, elevation, rest. Okay, so osteoarthritis and the drug therapy, there's not anything, no medication that can stop the progression of osteoarthritis. The purpose of the drug therapy is to reduce pain and inflammation. We talked about acetaminophen and NSAIDs. So you're gonna have your ibuprofen and your, there's other medications like Mobic is one that they can give chronic, for chronic arthritic pain. Diclofenac is a topical NSAID gel that you can put on the joints, and they sell that over the counter now. And then a corticosteroid or hyaluronic acid injection. So people can talk about getting a steroid shot into their joint or their pains at. And the steroids help with inflammation, and the hydrochloronic or not chloronic, hydrouronic acid injections helps with joint lubrication. Here's that Voltaren gel that you can buy at the store, Tylenol, of course, ibuprofen. So you wouldn't want elderly to be taking a ton of ibuprofen. So you'd want to try to find things you can mix with it to help with their pain, maybe alternate with Tylenol and the heat, those type of things. So here's some more non-pharmacological interventions. So rest with exercise. Exercise can help, but make sure they have plenty of time to rest. If don't push exercise if they're having, you know, more pain than usual in a joint. Position it in its functional position. So try to position their body in a way that's in line with the rest of their body. And then you can heat or cold applications. Sometimes people say heat hurts, some helps, some people say cold does, but just always monitor that temperature and to avoid burns. And a cold burn you can do as well. Weight control, ambulatory aids like a walker, glucosamine dietary supplements, and then medical marijuana can help with your osteoarthritis. Surgical management, there's really not any conservative measures to control the pain with surgery. You can't get a total joint. Like with arthroplasty, you can, like when they talk about a knee replacement or a hip replacement. So like it can create surgical creation of a functional synovial joint. We had a picture of that on something else. It's the most common places are in your hips, knees, and shoulders. Any contradiction, of course, would be infection anywhere in the body. Because with those surgeries, you have to be very aware of infections. Not that you don't for everything, but you'll see people that get infections and it can be from that joint that they put in their body. Now, it's not super common, but it is a risk. And so that's why you don't want any infection, you know, that you can detect anywhere in the body. High blood pressure and diabetes must be controlled to avoid post-op complications, and then quit smoking. Oh, here we go. Here's a picture of that joint replacement. So you can see where the hardware is put in. They drill a hole down into, and they put this part down in there, and then they connect that to the joint. Is that right? So pre-op, if they're going to have arthroplasty, they have a joint coach or a caregiver for pre-op and post-op phase. I know I don't know about other places. I'm sure they do it too, but they have joint camp at St. Mary's when they do like a knee, hip, whatever replacement. And so they do pre-op and they talk about what exercises they need to do, maybe about what kind of mobility aids, things to have ready in their house, those type of things. So the preoperative rehabilitation, prehab, I guess, it provides quicker recovery after surgery. And there's lots of patient teaching to prepare for arthroplasty. And this is an elective surgery, so pre-op requirements must be met. So a lot of times, so if people come in and they're like, oh, my hip hurts so bad, I think I need a hip replacement, they're going to say, well, we have to start with physical therapy. So you do physical therapy and then they come back in and it's like, well, that didn't help. And so then, maybe if they can give a shot, a steroid shot in the joint, or, just a steroid pack or something to see if that helps with the pain, because sometimes that can last a little longer. Even after the shot, like can last for quite a while sometimes. Anyway, you have to meet all those requirements before they'll replace a joint. If you're very young, they won't replace it, and I'm talking like in your 50s, because they do wear out. So things you'd think about before you would have an arthroplasty is make sure your medical conditions are all intact. So like if you have any issues with their heart, they're going to send you to a cardiologist to get clearance to have surgery. It's a big time commitment because you're off work. Schedule all your physical therapy. So you're going to know who you're going to go to for your physical therapy, what your plans are, going to have any assistive equipment you may need, and then rearranging your home. So put things close to you that you can reach easily. Things like that. Sometimes maybe if you have an upstairs bedroom and bathroom or whatever, you might want to maybe get a bed to stay like downstairs or another room so that you can get to the bathroom and you don't have to climb up the stairs as much. Typically in the hospital, you'll be in there for 3 days. The most common complications are hip dislocation. It can be usually caused by or detected with a neurovascular assessment, and you're going to look for one leg shorter than the other or rotation. Other complications include a venous thromboembolism, infection, and complications of decreased mobility, which could be a fall. Anticoagulants several days post-op. So have I had anybody take care of a hip replacement or shoulder knee replacement surgery? What was the anticoagulant they gave them? Mm-hmm. Do you remember, Victor? I know you had one. Alva, any of you taken care of a joint replacement patient? Not yet. Lovenox. You'll see people give Lovenox, that shot that they give in the abdomen to around the belly button. That was a very common anticoagulant they give after surgery. Early ambulation and exercise are important. If you're going to have this surgery, if it's early in the morning, there's a chance they may try to get you up that evening. They will get you up the very next day after surgery. Getting you up and moving is very important. And then, of course, you're going to monitor the surgical site for signs of infection. Sometimes you'll see people come out of surgery with a nerve block. I haven't seen that in a really long time, but doesn't mean they won't do it. And then NSAIDs and gabapentin for pain control. And you may see them getting narcotics like hydrocodone as well for the acute pain after surgery. So you're going to want to evaluate your patient with osteoarthritis. We talked about the pain control. And then, of course, what pain level is acceptable to the patient. Okay, so you're going to make sure they don't have any complications from their total joint. And then you're going to make sure they can move and function in an environment independently with or without assistive devices. So now we're going to go on to rheumatoid arthritis. So I have a story about rheumatoid arthritis before we get into it. So prior to this, I was a school nurse for 10 years. And so I had a little girl that would come in all the time, tell me her knee hurt, her knee hurt, her knee hurt. She'd get late to school, be late to school because her knee hurt. And I was just like, they had taken her to urgent care clinics and they were just kind of blew it off. And they were Spanish speaking family. So English was their second language. And so I just kept thinking there's something wrong with this kid. And so I had to figure out who the pediatrician was, find out her, because they were on Sooner Care. So you have to make sure to find the pediatrician that's assigned to them. And so I did that, and then I made them the appointment, and I told them kind of what I saw, what was going on, and what, I feel like there's something wrong. And so they went in, and she was diagnosed with rheumatoid arthritis. And so I was really surprised. But anyway, so there was other things that were made. She had a plan so she could come to school maybe a little bit later because of that early morning joint stiffness. But anyways, I felt pretty good about that. Anyway, so rheumatoid arthritis, or it's also known as RA, it's a chronic progressive systemic inflammatory autoimmune process. Let me say that again. It affects the synovial joints, is caused by cartilage deterioration, is characterized by remissions and exacerbations. You can have permanent joint changes, and they may be avoided if they're diagnosed early. Physical and emotional stresses are linked to exacerbations. So this is an autoimmune disease. Common joint deformities seen in RA are the boutonniere, the way the fingers deform it up here, and then the swan neck, looks like a swan. So things to assess for possible RA, know that it's acute and severe or slow and progressive. So it can come on quickly, or it can be something that kind of waxes and wanes and gradually progresses. So on the systemic assessment, physical assessment, you're going to look for joint and systemic symptoms, fever, fatigue, weakness, generalized weakness and fatigue. Morning stiffness is a big thing with RA. Remember that, how that's different from osteoarthritis. Advanced disease and symptoms, which can be osteoporosis, severe fatigue, and muscle atrophy. So things you could find on assessment, on their lab work, they may have a rheumatoid factor, which measures the presence of unusual antibodies. So they'll do a RA titer, and if it's positive, that's an indication they have rheumatoid arthritis. They can check the anti-CCP, and it's very specific and sensitive in detecting early RA. They'll also check their SED rate, or the ESR, to see if it's elevated, and the C-reactive protein, which indicates the inflammation in the body. They can also do it with x-rays to determine joint changes, and arthrocentesis, which aspirates the synovial fluid, that fluid between the joints, and analyzes for inflammatory cells. So when you're collaborating, priority collaborative problems for patients with RA include chronic inflammation and persistent pain, potential for decreased mobility, and potential for decreased self-esteem. So on the rheumatoid arthritis drug therapy, we talked about NSAIDs. Typically anything you're going to see inflammation, they're going to give NSAIDs. You're going to want to give them something to protect their GI with chronic use of NSAIDs like Pepcid. There's immunosuppressive medications like methotrexate, which is chemotherapy. Disease-modifying anti-humeric drugs slow the progression, like hydrochloroquine, and then glucocorticosteroids. Anyway, so I wanted to talk more to you guys about the methotrexate. So it's an anti-metabolite which causes immunosuppression. So with immunosuppression, you can see that your white blood count is lowered, and that there's an increased risk of infection. So it's the first line of treatment for RA. So typically this might be a drug they start with. It helps slow the progression, which and reduces the joint inflammation, and it can also prevent permanent joint damage. So the methotrexate suppresses the immune system by blocking folic acid metabolism in rapidly dividing cells. It's a mechanism. This reduces the overactive immune and inflammatory response that damages joints in RA. And so think about it, it calms down the body's immune attack on the joints, the methotrexate. And typically, if you see methotrexate, you will see it abbreviated with that MTX. So just, that's very common, you'll see that. So common side effects of the methotrexate are nausea, fatigue, or mouth sores. The mouth sores are from the immunosuppression. They can lose hair thinning, increased liver enzymes, so you want to keep an eye on those. Like I talked about with the bone marrow suppression, the immunocompromised, decreased white blood cells, but you also want to watch for decreased platelets. So let's see, nursing considerations, you'll watch their lab work for their liver function, kidney function, and of course that CBC to watch your blood counts. Infection precautions, so you want to teach patients to report any signs of infection immediately, or like if they have a fever, tell them to avoid sick people, children, people coughing. Avoid alcohol because it can increase your risk of liver toxicity. And then, of course, the teratogenic warning for pregnancy, it can cause birth defects, and you avoid pregnancy during treatment and 3 months after. I wouldn't say it can cause, it probably will cause. Let's see. You're going to want to take folic acid with that. And you want to see decreased joint and swelling, improved mobility. It slows the disease progression. So on the hydrochloroquine or Plaquenil, does anybody remember hearing that drug back from a recent pandemic? They were giving it for when COVID very first started up. They were acting like that was the drug of choice. Not sure why they tried it, but anyway, just a little tidbit there. Let's see. So with the place, sorry. Okay, so it's oral med, and you have to take it with food or milk to reduce upset the stomach. It can take weeks or months to work. It's not a quick pain reliever. And side effects include GI upset, headache or dizziness, skin rash, and there can be serious side effects. The eye retinal toxicity is a big one that you need to watch for. So if they have any changes in their vision, like blurred vision or blindness, and they've been taking it long term, that needs to be addressed immediately. And they need to make sure they keep their eye exams, and it's good if they haven't had a baseline exam to get one too before starting. So you're going to want to manage or monitor for vision changes, and muscle weakness or hearing changes can be rare, but it can happen. You're going to educate your patient to take it with meals, report vision changes immediately, regular eye exams, and they may have to take it several months before they see any benefits from it. It's typically well tolerated, and there's less liver and kidney toxicity compared to methotrexate. And it says it's often used in combination with other medications like methotrexate. So you may see the methotrexate being given with the Plaquenil. So the methotrexate, it's like a chemotherapy. It's the first line. And then you're going to have the hydrochloroquine or Plaquenil. That's the anti-humeric drug that you can be seen as well. And it takes longer to work. And they give it with the methotrexate, and you need to watch for vision changes. Arthritis management, or RA, promotes pain management and modified behaviors to complete ADLs independently at home. So you're going to use assistive adaptive devices. You see those pincher things, it's long and it has a pincher on it to pick up things maybe on the floor. Velcro shoes, long-handled devices. Only sleep with one small pillow to decrease pain. And then when you're lifting objects, always lift with your knees. Okay, So for evaluation, you're going to check their pain scale and if that's acceptable to them. If they can move and function in their own environment independently with or without assistive devices. And that would be maybe where occupational therapy would come into play. They could teach them, how to perform their activities of daily living. Maybe have to modify a little bit for their pain or for their decreased range of motion. And then they can verbalize and increase self-esteem and positive perception by taking the medications and feeling better. So here's a little graph to show the differences between RA and osteoarthritis. So typically the onset can be in younger people, 35 to 45, but you can also see it in children. Typically osteoarthritis in older people generally affects females. Risk factors, so RA is an autoimmune disease, and you can cause flares with emotional stress or environmental factors like the weather. Osteoarthritis is usually you're a risk for aging, obesity, trauma, and occupation. The disease pattern on RA is bilateral, systemic, multiple joints can be affected, affects upper extremities first, and it's systemic because it's autoimmune disease. So with osteo, you'll see aging, obesity, trauma, and occupation as risk factors, and it can be unilateral, meaning it can involve a single joint. Usually affects your weight-bearing joints like your hands and your knees, and it's non-systemic, so it's isolated to the joint. Common drug therapy for RA, we talked about the NSAIDs, the methotrexate, and the biological response modifiers, which is the hydro or Plaquenil, it's easier to say. And then for the osteoarthritis, of course, NSAIDs, Tylenol, and other analgesics like, stronger pain medicines. So question 1, which assessment data does the nurse anticipate in a client with osteoporosis? Morning stiffness, elevation in ANA and SED rate, involvement of weight-bearing joints, and systemic appearance of disease process. Talking about osteoarthritis. What do we think? What? C, good job. Yep, all the other things go along with rheumatoid arthritis. And that's it. So bear with me. My ENA people know I get kind of excited about dumb things, but I made a Kahoot for arthritis. So we're going to try it out. Okay. So I'm not sure. See how we go. Okay, so I start it and it'll show you the code. So you guys have it. You guys got it? Everybody ready?
I'm there yet.
Oh, it shows me the number of participants. Right now, I think it says 0. Can you, you can scan that with your, Janie's on. Oh. So fun. We have maybe. Is everybody in here on? Are you good, Nalva? Okay, here we go. We're gonna start now. Ready? Oh, here's a couple more. Oh yeah, let me wait a minute because we do have, I think, 27 total. Okay. Okay, here we go. Autoimmune disease. We had one age-related issue and joint wear and tear. Those are things that you would see in osteoarthritis. Let's see. Oh. This is fun.
Wait.
Hey, morning stiffness, good job. Muscle weakness. That would be with osteo. What's a common treatment for RA? Yes, steroids. Which test is used for RA? Oh, this one's a good one.
What's the free one?
X-ray. Good job. Blood test for antibodies. So can I give you guys a little clue to think about this if you're taking a test? An MRI, a CT scan, an X-ray are all imaging, right? So which one's different would be the blood test. But so just kind of think about those things when you're taking tests. If something is specifically off, different, it may be the answer. So yes, you blood test for antibodies. It's an autoimmune disease, remember? Okay. Risk factor for osteo. Smoking. Obesity. I know a lot of you said smoking, which can be as well, but obesity is the most common. Common imaging test for osteoarthritis. MRI. Do you hear me? MRI. Yes, just a regular old X-ray. That's how it's the most common way to find it. Oh, Maria is the highest climber. Way to go, Maria. Oh, this one's for double points. Common complication of rheumatoid arthritis. Oh, that's why you keep asking. Liver failure, it says. Yes, joint deformity. Good job. Everybody got that one. Okay. Yay, Emma, you won. Good job, Emma. Way to go. Sarah got second. Or no, Emma got third. Sorry. Phew, you got first. Okay, I don't know if you guys enjoyed it as much as I do, but that was pretty cool. All right. So how do I get out of this? Stop. Okay, so now we're gonna move on to everyone's favorite. It would be trauma. I don't know if it's necessarily your favorite, but it can be pretty fun. Okay. Let me get my computer brought it back up. All right. We're going to talk about the different types of fractures, how to interpret the findings, and how to assess for those things, discuss safe and evidence-based nursing care to maintain casts, and then nursing interventions that help prevent and monitor for complications related to fractures. As a school nurse, if any of you become one, you'll get very familiar with broken bones, most typically arms. So fractures, what is a fracture? It's a break or disruption in continuity of a bone that affects mobility and causes pain. So they can be classified as complete or incomplete, open, which is a compound fracture, or closed is a simple fracture. Fragility, which can be pathologic or spontaneous, fatigue or stress fractures, and then compression fractures. So you got some pictures here, and you need to know the differences in these types of fractures. So an open and closed, those are pretty, you can see at the side there, it's pretty self-explanatory. The bone can break through the skin, or closed fracture, it doesn't break through the skin. Some of those that are pictures of an open fracture will show it like bulging. It's maybe not broken all the way through the skin, but it's bulging to the skin. Let's see. Let me fix mine. All right, so you have the stress fracture, which is down in the black box there. And it can be caused, it's a small crack or severe bruising within a bone caused by repeated mechanical stress rather than a single traumatic event. So an open fracture would obviously be a traumatic event, and a stress fracture would be a chronic repeated stress. It's often called an overuse injury. Athletes are really prone to this. Working out or whatever, using poor training surfaces like uneven ground or the dirt, cement, those can all make a difference. Osteoporosis, improper footwear, and then adolescents and children with their growing bones are vulnerable. I can give an example for this one. My daughter, she did the long jump and she did hurdles, and she got a stress fracture in her foot, which you can imagine that constant pounding on your feet. So that's something to kind of, you want to put that into help remember. And then the compression fracture is on the spine here. So you can see where that little V shape, that's can indicate a compression fracture. Typically can be from a fall or car accidents, or it can be a pathological fracture from weakened bones. Things that could weaken the bone would be cancer, infection, or other diseases. The fragility fracture that is a low level of trauma that would not break in a healthy bone. So something that wouldn't break in probably a young, healthy person. And that's usually caused from a fall standing at their height or less. So that could be a big sign of osteoporosis. So when you see people fall, just, like elderly people, maybe they fall and break a hip, well, they can fall and cause these compression fractures in their spine. So the difference is the compression fractures usually from its trauma, and it's that V shape. The fragility is from a low level of trauma, like falling from standing height. And then the stress fracture is the overuse. And then the compression fracture, where we talk about oh, you know what? I think I got this. So the compression fracture is the spine, and I was saying the stress fracture. The stress fracture is from overuse. Sorry about that. We got that? Clear as mud? Anybody have any questions? Okay. So here's some pictures of different types of fractures. An impacted fracture is when bones endure forceful impacts. They might face an impacted fracture. This type of break happens when bones are compressed or get squished, causing the broken ends to push into each other usually from falling or trying to break a fall. This was the common bone break I would see in school with kids, like they would go to fall, then they try to break their fall. Usually would happen in the wrist, but it would happen in the upper arm as well. But it's pretty common. And I always tell kids when they're running in PE and you probably remember doing it in elementary school, you run up into the mats and you slam into it with your hands, you're going to break a wrist. Just saying. Comminuted fracture. Anyway, happens when you break a bone into 3 or more pieces. So you can see in the picture there where it kind of breaks into more pieces. A spiral fracture occurs when there's a twisting force is exerted on a long bone, usually causing it to split along its sleeve. These fractures commonly happen in the arm or leg. Unfortunately, if a child comes in with a spinal fracture, it's a concern for possible abuse. You can see people like, think about a kid's walking along and you grab their arm and twist them back. That could, that'll show up on a x-ray, and that's usually ends up calling DHS if they see those in a child. And sometimes you can see old fractures that have re-healed, like a green stick fracture. A green stick similar to the displaced spiral, but it's not displaced. You can see where the bone is kind of splintered from being twisted. And then the displaced transverse is where the broken ends of the bone are separated and they don't line up correctly. So know those different types of fractures. Okay, so then we talk briefly about the stages of bone healing. So in the first 24 to 72 hours after the injury, you develop a hematoma at the site of the fracture because the bone's extremely vascular, which causes swelling, pain, and redness around the fracture. So then on stage 2, which can happen 3 days to 2 weeks after injury, granulation tissue invades the hematoma, which can start providing stabilization. And then stage 3, which occurs 3 to 6 weeks after injury, it's when the fracture is surrounded by new vascular tissue called the callus. And the bone strength gradually increases, but it's not completely restored at this point. And then stage 4, 3 to 8 weeks after surgery, the callus is absorbed and transferred into the bone. This is when the bone can regain its original shape and structure and strength. It starts strengthening basically. And then 4 to 6 weeks after the injury, or it can even be up to a year depending on the break, you have the consolidation and remodeling of bone, and it continues to heal basically. So the complications of fractures, of course, you want to talk about the DVT and a pulmonary embolism, blood clot that can go to the lungs, bone or soft tissue infection. They can develop acute compartment syndrome, and this can be you need to pay attention for, that needs to be addressed quickly. It occurs when the pressure builds up within the closed muscle compartment, and it's usually in the arms or legs, and it reduces the blood flow to the tissue, which can cause ischemia, cause it to die. It's a surgical emergency. They have severe pain. And they can have paralysis, weakness, or inability to move the limb. The pressure, they'll say they have tense, swollen, in the compartment. It's that pain, that pulsing pain. And they treat that with a fasciotomy. So anyways, so that can be a risk of a fracture. And then a fat embolism, just it's flat globules that are released from the yellow bone marrow 12 to 48 hours after injury. The globules block small blood vessels and they impair organ perfusion, which this one kind of makes you think of like a DVT, because the most common site affected is the lungs, and just like a DVT, that's an emergency, like kill you quickly. So the fasciotomy is a surgical procedure, and it involves cutting the connective tissues around the muscles to relieve pressure and restore blood flow. So you're having this terrible swelling and the muscles can't go anywhere. And so you're going to cut this, put incisions on there to open it, relieve the pressure. And then it's left open for several days, and then they cover it with a skin graft once the inflammation has subsided. super high risk for infection. So if you're leaving an incision open for several days, which is covered with sterile dressing, infection, super high risk. Leaving an incision open, super high risk of infection. Okay. So to assess for fractures, you're going to determine the cause of the fracture. You're going to ask about events leading up to the injury, what happened, if there was any substance abuse involved, and then occupational and recreational activities. So like, do you like to go ride motorcycles? And then physical assessment, signs and symptoms, you're going to look for trauma to the other body systems. So just because you have the fracture, there's other parts of the body that could have been injured as well, that they may not hurt as bad because the other hurts worse. I have an example of that. Had a kid fall off the swings in middle school, and his arm was a displaced fracture. So you could see, you know, Z-shaped arm. And he was, of course, in a lot of pain, and the ambulance came and they gave him pain medicine. But then he was like, my other arm really hurts too, but obviously this one was deformed. So you're like, he broke both of his arms. So there you go. You could see where this arm would be the priority. All right, so you're gonna check for the other areas of the body. Neurovascular assessment, check their pulses, very important. And assess for range of motion, strength, pain, and tenderness. So can they bend it? Does it hurt to bend? Can you, if you palpate it, is it tender? Is there swelling that shows up? Sometimes with fractures and whatnot, you can have instant swelling. And then their strength. So you check their strength. You know, can you squeeze my hand? You know, can you push your toes down? You know, push on my hand, push your foot into my hand. How about that? Those type of things. So on an assessment, you would want to check the hemoglobin, hematocrit, their SED rate, white blood cell count, and then your serum calcium and phosphorus. Imaging assessments, x-rays, CT scans, and MRIs can show a break. Sometimes they'll do an x-ray or an MRI or CT, and there's too much swelling like in the very beginning, and it's hard to see it. They can't see it. So they may splint them and then wait a couple of days and re-image, and it shows up. Or they can be told by some, I've seen, that they don't have a break and they still have a lot of pain, and they come back and they're like, well, we couldn't see it before. So outcomes, you want to adequate pain control, that they can ambulate independently with or without assistive devices. They're free of physiological consequences. So that could be, you know, bed sores, pneumonia, like because they're not able to move around as much. You want to make sure they have adequate blood flow, and then that they're free of future fracture complications, which again, we talk about the bed sores and those type of things that can come up. And then caring for a cast. So the fiberglass casts are hard and they wrap around to immobilize broken limbs. So that's a hard cast, you know, do you want to sign my cast? Type of things. And with those, you want to always do a neurovascular assessment, and often, and you'd want to teach a parent or someone that's going home with a hard cast what to look for. So you want to make sure they can wiggle those fingers, their toes, that area is warm to touch, it's not cold. If you can check for pulses, of course, and then the color of the skin, if it starts to get kind of pale, think of like you're putting pressure on something, it's not getting flow. So look for those things. Because there can be sometimes their cast, it seems like it's a good fit and then they leave and it might be too tight. So for pain, you can use NSAIDs, elevation and rest. You want to, if they look and see if they need help with mobility or using assistive devices, and then of course cast care. Has anyone had a cast? Ever broke a bone and had to wear a cast? No? Nobody? Oh, did you and Alva? Oh, you guys had a lot of broken bones. Well, I want to somebody tell me how you took care of your cast. So what were some of the things you guys were taught to take care of your cast?
Don't get it wet. Yeah, don't get it wet.
Right? Keep it dry. What else?
Don't stick anything down.
Exactly, yeah. Might put something down in there and you could cut yourself and then get an infection down in there. That wouldn't be good. And then, yeah, talks about don't put anything down in there to scratch because I've been told by a lot of people that it gets really itchy down in there. Don't cut on it or try to pull it loose. And then do not, what does it say, drive or lift anything heavy until the cast has been removed. I've seen kids playing sports with their hard cast on, so, you know, they must be pretty good. So you want to notify your doctor if the skin around the edge of the cast is painful, swollen, or red. So like, is it cutting into your skin? If it's cracked or it has soft spots, seems too tight or loose, and if it has a bad odor coming from inside the cast. And then any coldness or tingling sensation when your skins touch, like your fingers if you're wearing an arm cast. And this talks all about ORIF. That'd be like your joint replacements and then skin traction. Oh. So we're going to go more into these, but here's a nice little graphic on your slides. Okay, so we're going to talk about traction. So traction is an application of a pulling force to a part of the body to provide bone reduction. So we're trying to get that bone pulled back into place. Patients in traction are usually hospitalized. I can't imagine doing that at home, but weight must remain hanging freely. So I'll show you that in a minute, what they're talking about at all times. So skin traction involves a Velcro boot. It's called Buck's traction. And this decreases painful muscle spasms. They see it used with hip and femur fractures, and usually the weight on those are 5 to 10 pounds. Now with the skeletal traction, there's screws inserted directly into the bone that are like, you can see outside the skin. They come outside of it. And it aids in bone realignment, but impairs mobility. Yeah, you can't get up and move around if you're in traction. And that involves 15 to 30 pounds. You're going to want to make sure you take care of the pin sites and tissue integrity. So this is traction. So over here on the patient laying in the bed, you can see his full body. That would be Buck's traction, and that's the skin traction. So they wear this boot, you can see on his foot, and it connects to the wires, literally. And then you can see where it goes over the, what do you want to call that? Not a hinge, levy. And then you can see the weight. So they can change the amount of weight depending on the size of the person, of course, and then how much traction they want, how much pressure they want put on that to relieve the muscle spasms or help with reduction. And then on this other picture, the skeletal traction is just what it says. So the top picture shows where the pins go into the knee, or you'll see when they talk about the pin care, taking care of that site. And then they have the weights like the, other, but it's being held into the bone for reduction. You might see these with a halo with the skeleton, like the head. I don't know if you've ever seen them. It's the round and it has the screws. The pins go directly into their skull. So it's kind of different. You don't see it very often, but it usually happens in trauma cases is where I've seen it. And then there's the different kinds of mobility aids that go along with all of our fractures we're talking about. So walking canes, those are for minimal support and they're easy to maneuver in tight places. And then the quad canes, they're more stable. They provide more support compared to a regular cane. Your walkers, for people that have balance issues or need support on both sides, and they're lightweight. Rolling walkers are used for those with limited upper body strength, and they're easy to maneuver around tight corners. And then standard wheelchair chairs are for those with major mobility issues, and they have sufficient upper body, they have the strength to be able to push themselves. And then the scooters or electric wheelchairs, they're less physically taxing than the standard wheelchairs, obviously, easy to use, And then crutches are used to help a person walk when one or both legs are injured, weak, or non-weight bearing. So some things you'd want to think about with the crutches is the underarm pain you can get from using crutches. If they're not using their crutches correctly, they'll get that pain because you're not supposed to put, when you're walking, your weight bearing under your arms. But it happens. And then amputation is the removal of a part of the body. It may be elective, like if you have diabetic ulcer or something, or obviously traumatic. There's different levels of amputation, and the complications include hemorrhage, infection, phantom limb pain, neuroma, and flexion contracture. So I'm going to go into a little more about amputation. It's often necessary when a limb cannot survive due to poor blood flow, infection, or trauma, like we said, or cancer. So diabetes, what comes along with the peripheral vascular disease, severe injury, and malignancy are the most common pathological reasons. So, so what you can see with the diabetes, you get peripheral vascular disease, which the PVD can come from other things, but we do know that comes along with the diabetes. And so you can develop non-healing ulcers, gangrene, and tissue necrosis. So the tissue starts to die. So with the diabetic, they have the decreased blood flow, and then we think about the peripheral neuropathy. So they don't know if they have an infection or trauma because they have poor circulation and they can't feel if they step on something. My father-in-law's a bad diabetic, and he stepped on a splinter on his foot, didn't know it was there. He got massively bad infected, and he got osteomyelitis from that. So that's why we talk about diabetics taking care of their skin, taking care of their feet is very important. That's why we talk about the appropriate shoes, make sure their shoes fit, because those ulcers can lead to serious complications, including an amputation. And of course, trauma, if there's any irreparable damage to their muscles or bones and vessels, crush injuries, like a severe crush injury, burns or avulsion injuries, avulsions like electric. And then infection, osteomyelitis, a bone infection, obviously, necrotizing soft tissue infections like gas gangrene. Which, if you ever see that, you'll never forget it. The smell. So let's see, we talked about. So this kind of goes over what I already talked about, the peripheral vascular disease, like in diabetics, the atherosclerosis, chronic ischemia can lead to non-healing ulcers, which can get infected. Diabetic conditions, the peripheral neuropathy, they use the loss of sensation, poor circulation, impaired wound healing. Trauma, severe crush injuries, burns, or avulsions, their injuries. Infection, we talked about that. Tumors. So bone tumors, like you would see in malignancy, an osteosarcoma or Ewing sarcoma are the most common reasons. And you can see those in children. A lot of times, like if a kid's missing a limb, other than trauma, it can be because of osteosarcoma. Let's see. Congenital or developmental defects, rarely seen, but if they have severe limb deformities like that impair function and they can't attach a prosthetic to it, they may be able to amputate the part that they couldn't attach a prosthetic to, or that was too severely deformed. And then compartment syndrome, what we talked about before, or severe vascular compromise, if those things aren't dealt with immediately, it can cause irreversible muscle and nerve necrosis due to prolonged ischemia, no blood getting to it. So there's common levels of amputation. You have the above knee amputation, which is the removal of the leg above the knee joint. This includes part of the femur, but leaving a residual limb, or the stump, they call it, for prosthetics to fit into. So you see people with the above knee and they leave that, little bit of their femur. Now you can put a prosthetic on it easily. Then you have the below knee amputation, which is the surgical removal of the leg below the knee joint. Again, preserving the knee joint for improved mobility and prosthetic function. So, you got that. The SIME amputation is the surgical removal of the foot, and that's in this blue box picture, at the level of the ankle joint, preserving the heel pad so the patient can bear weight on the residual limb. So I don't know if you can see, it's kind of a small picture, but they remove that and they want to leave the heel pad. So that front part of the foot they take off, and so the heel pads, they pull it under, and then they pull it all the way around and sew it to the top of the foot where the top of the foot would have been. Ankle disarticulation amputation is the surgical removal of the foot through the ankle joint. So just like it says, right through the ankle joint, separating the tibia and fibia along without cutting through the bones themselves. And then the partial amputation, foot amputation, involves surgical removal of a portion of the foot, such as the toes, the forefoot or midfoot, while preserving as much as the foot as possible. You can see that with trauma, maybe someone cut off their toe with a lawnmower. And then also, of course, with ulcers, diabetic type ulcers. So to prevent amputation, you want to adhere to diabetic disease management plans, then a healthy weight, maintain a healthy weight, regular exercise, avoid smoking, and avoid risky vehicle behaviors, and always use appropriate precautions. On assessment with an amputation, you want to monitor that neurovascular status and phantom limb pain, which is a thing, and take it seriously. Ask them about their pain. There's some things you can do for it, but it is a thing. And then the psychosocial assessment, they do not understand their feelings of loss, even though it's a smaller body part, like it can be like their thumb, and they go through a grieving process. Also, they are concerned about how it looks, So planning and implementation, you want to monitor for decreased tissue perfusion and watch out for that. Manage their pain. If they have the phantom limb pain, they'll use Neurontin or gabapentin a lot for the nerve pain. They can use beta blockers that can help with that dull pain. And then baclofen, a muscle relaxer for muscle spasms. And then to promote mobility through limb prosthetics, and then of course with physical and occupational therapy. And then to promote self-esteem, there's organizations that they can join, like the Amputee Coalition of America and the National Amputation Foundation. So here we'll talk a little bit about the care of someone with amputation. So you're going to want to elevate the stump the first 24 hours. Keep that elevated. Don't want any swelling. It'll help prevent contracture of the joint above amputation. So this is for the stump wound care. This is the part that's left. You want to talk to your patient about phantom limb pain, about pain medicines. You're going to evaluate the healing. With those, typically I've seen staples. They staple it. You want to make sure that's good and close. With a above the knee amputation where they have the stump, and they put their stump down into it, they really want to make sure they develop a healthy stump. And so with the amputation, they can be stapled like straight across, and you'll have those little tags at the side. So they want to get the stump on as early as they can to try to like mold it so that it fits well into their prosthetic. Let's see. Compression socks, compression dressings, that's another thing they'll do. They want to keep that compression on it to help mold that stump, to keep it, where it'll be good for prosthetics. So the compression sock for the stump is very important. And that's something they'll do throughout their life. Let's see. It says discourage semi-Fowler's position the client with above the knee amputation to prevent contractures of the hip. That makes sense. And then, of course, observe for bleeding. So aftercare, let's see. You're going to want to assess for skin breakdown. You're going to make sure you want to keep the stump clean and dry. Don't apply anything to the stump. No alcohol to dry it out and any lotion or anything like that. Make the skin too soft. Antibiotic ointment, none of that. Encourage the client to wear their prosthesis when he gets up and all day to prevent stump swelling. So yeah, the sock will prevent that swelling so they can wear their prosthesis and it fits appropriately. So you want to make sure that you prevent further loss of circulation to the extremity, promote comfort, of course, promote optimum level of mobility. So we've reached the end and I have another Kahoot for you guys. Understanding bone fractures. Here we go. I think that's how many we have. Okay, here we go. Understanding bone fractures. Bone into multiple pieces. The communid. I cannot say that word. I want to say communicated, communicated. Anyway, yes, that's the correct answer. The green stick fracture is the twisting. Remember, it's the twist, the spiral. What does open fracture mean? I'm not really sure where this picture came from. I guess I could turn the closed captioning off. The green is the bone inside the skin. Oops, sorry. Partial break. It doesn't break all the way. It's that twisting motion. You see some of it broken. Which vitamin helps bone healing? I don't know this one. Very good. Vitamin D. And you have to have vitamin D to absorb calcium. Good job. What's the purpose of traction in fractures? Good job. Doesn't do these things. It's not going to increase your mobility because you can't move while you're in traction. Just remember that. Which type crosses the bone horizontally? Transverse. Think transverse, like breaking across straight. How do you prevent fracture complications? Yes, monitor circulation. You don't want to avoid movement because you want that to heal. You can't, if you don't move, you're gonna freeze that joint up and it won't work. You've got to keep, and plus the complications that come along after surgery from a fracture, you've got to keep moving. So you're gonna want to monitor circulation, talked about. Okay. Oh, is there one more? What's the main cause of pathological fractures? Bone disease, it's pathological. Pathological. Think of that. Inside the body. All right. Think about path. Can't think of what I'm trying to say. A&P, anatomy and physiology. That's inside the body. Pathological is inside the body. Anyway, okay. Well, I'm finished. Thanks for enduring. I'll see you guys next time. Do anybody have any questions? I didn't ask anybody that. I guess it's too late for that. Do you guys have any questions in here? No? Oh, you got a second. Janie. She's on it.
Got some story bridges in my think that. It was fun.